Yeah, cool. Thanks.
Yeah, with the lectern, Mike, or did you want to?
No, that should be fine.
Yeah, cool.
Easy.
Alrighty, we'll make a start. Please feel free though, if you're still at the back grabbing some drinks or food or anything like that, absolutely no problems to go for it. The first couple of days we do have 3 presentations, and that's why we kind of are moving through a little bit quicker. So our Thursday and Friday we do just have the 2 presentations, so we will have a bit of a longer break between the 2 sessions. One thing I haven't talked too much about is the photo of the day competition. So this is how you can win big prizes. We've got a bunch of gear from Ski Mapper, we've got some vouchers, I think we've got a few hoodies and whatnot, a few neck scarves and balaclavas that you might get a chance to win during this presentation as well. So the big one here is that it does need to be posted up to Instagram by about 3 o'clock each day to be in the running that evening. What happens is that Dylan and I will then choose sort of the top 5 to 10 sort of photos. We'll whack up to the screen, loudest cheer gets a prize. We may be able to do a prize bonanza on Thursday, so something to keep in mind, but generally at the start of the week we have less entries. So if you've got any good ideas, any good photos, now's the time to get them up on Instagram. The details of what hashtags and whatnot to use are through that QR code. If you are having troubles uploading it, feel free to send it straight through to our email and we can put it up on your behalf. That's me. So let's hear it for Mark, who will be doing our second presentation tonight.
Thank you. Thanks very much. So I'm a retrieval doctor from Alice Springs Hospital in the Northern Territory. It's a little bit warmer there here than it was when we landed in this place, so I'm still getting used to the temperature change. I'm just going to go through a presentation on blunt chest trauma that we've had in Alice Springs and its surrounding area, which we'll go through. So I trained in Ireland as a general surgeon. I hated it, sorry. But I did emergency medicine, thankfully, during that time and switched to that. And then I've had quite a few different jobs since I moved to Australia. Currently in Alice Springs doing retrieval, and I'm also a rural generalist, so that's a GP for people in the middle of nowhere. And I've just signed up stupidly to do the diploma in pre-hospital and retrieval medicine. So when I get back, I have to pack my house and move to Queensland. So that's going to be fun. I've got no conflicts of interest. So this presentation is going to be about pre-hospital management, and it also relates to Central Australia. Anybody here been to Central Australia? I know there's a lot of Alice Springs people here, which is woohoo. So it's a very large area. It's very remote. To get from A to B takes about 4 to 12 hours, and that's just a drop down the road. So it's very large areas. I'm going to talk about 3 cases, and it's obviously going to be chest trauma stuff. And a few things that won't be covered is actual penetrating chest trauma, which is completely different, and also traumatic cardiac arrest. That's a different kettle of fish altogether. So this is what we work in. That's one of the RFDS PC-12 planes on the left, and the fabulous massive standard troopy that you have, which has about 2 feet between the stretcher and the roof, and I never fail to hit my head getting out the back. And that's the inside of a PC-12 on the right. You can see there's very little room. Not a lot of room to do much in there, so if you've got to do something, you've got to do it before you get in there. This is a lovely clinic that I used to work in called Tea Tree. So you can see it's a small little clinic. It's got one emergency room which has got 1 trolley for the patients. It also has 1 trolley with a defib, and there's a troopy there in the parkway. And on the right, that's Tea Tree airstrip where we land with the little planes. So this is one of my favorite airports. It's called Wallara. This is the international terminal. And you can see the VIP Qantas lounge on the right. They've got a sense of humour in Wallara. And this is the area that we're talking about. So it's pretty big. We go from as far north as a place called Elliot, down into the South Australia in the AP Wildlands. So it's about 150k south of the border. We go to a tiny little place in Western Australia called Kirakara. Anybody heard of that place? The Jewel of the West, apparently. We have another name for it, but I can't say that here. I will say that apparently spears were thrown at the PC-12 that was taking off a few years ago. So, these are my road trips to work and back, because I also work in Kings Canyon Clinic, which is a fantastic place to work. But this is a 100k dirt road trip, which is part of the 400k to get there. You can see the roads are long, they're very straight, they can get quite boring. So you've got to watch out for certain things that you'll see on the way. In the Northern Territory, these are the causes of motor vehicle crashes. You got a few, these camels I came across driving to Kings Canyon. There was quite a few of them, and the big guy in the middle on the road was not very happy with me. You'll see this little red arrow at the edge of the road. The sides of the roads, they're not very good roads in the NT. The edges can often get eroded away, and if you hit that going at 130k an hour, which is the speed limit, and lots of people do 130k an hour, especially if you've got a 4-hour drive to travel 500k, they'll put the boot down. But when they hit that, what happens is the wheel starts jiggling and they get scared, get a fright, so they overcorrect. So they'll swing the car back in, and then the car usually just flips, because it's usually 4-wheel drives or camper vans and things like that. So motor vehicle crashes and rollovers are very, very common. There's a few horses there in the middle, and I did a bad thing one day driving to work 400k. I left too late, and it was sunset and it was getting dark. Never drive in the NT on dirt roads in the dark, because the first picture, you can barely see anything, and about 10 meters later, there was a big bunch of cows there. Thankfully, I was only doing 40. Male, maybe 50. So, quiz 1. Anybody know what mountain that is? There is a prize. Mount Fuji. Who said it? You can come up and collect that later. It's too far. My arms are sore from the ski. So I'm going to talk about case 1. This occurred at 3 a.m. It's a call to the retrieval service saying there's been a car rollover and there's 4 patients in the car. It happened in South Australia in the AP Wildlands, so it's quite a long way away. So when you're on the end of the phone getting this message, what are you going to do? It's 3 a.m. You've only got one doctor in the office that's going to get on the plane. You only have one plane. That plane only also has one pilot and one nurse. It's 3 a.m. You have the option of a second plane early activated at 6 a.m., but they won't get off the ground for 45 minutes. So you have very, very limited resources. You have to call the night crew in. You will be activating the day crew early, so it's good to give them a bit of a pre-warning, but that's about a 5:30 a.m. call. You need to let ED and Alice Springs Hospital know that something's going to be coming in. You can also, because it's in South Australia, there is an option that you could transfer those patients to Adelaide. So you need to think about a lot of things. St. John Ambulance will be needed to transfer the patients from the airport in Alice Springs to the hospital. It's about 20k drive. So, and you also need to think about the doctor that's going on the plane, the nurse. They're coming close to the end of their shift at 4 a.m. So you're going to be sending them on a very long journey. Also in the clinic, you want to know how many staff are there. Usually it's one remote nurse and maybe a second responder. In the place that this happened, they're lucky that there's fire and rescue, which is probably 2 people, one of whom was the policeman, and only 2 policemen. So you've got very limited resources there. They're going to be tired. Do they have enough space in the clinic even for 4 patients? And then you've got to be careful of flight crew. Are they going to be tired? And how much equipment can you send? Because these planes are small, they can't carry a lot of stuff. So all these things you need to work out and you need to do quickly because you need to get things going. So that was the picture that we got of the car. It's a bit of a mess. So there was 3 patients. The first one was possibly ejected, did have LOC, he was amnesic to the event, and he was also intoxicated, which makes everything much more difficult. The patient we'll concentrate on is HD. He possibly self-extricated, was complaining of right chest pain, and had some mild respiratory distress. There was another patient with what sounded like neck injury and a head injury, and also the driver itself. He had self-extricated, multiple cuts and grazes, but actually left the clinic 45 minutes later, didn't want to travel anywhere. Family came and took him away. So this is where we are. Alice Springs is at the top, and the crash site is the little star, which is about 10k along a dirt road near a place called Marla, which is in the middle of nowhere.
Minterby, isn't it? I know it. Minterby's near Marla Trucks.
Yeah, that's exactly where it was, Minterby. Yeah. So this patient, the clinic arrived at the scene. They say it was possibly 100k an hour rollover. This patient, HD, he was 29-year-old male. He was intoxicated, no loss of consciousness, but was complaining of severe right-sided chest pain. They said they listened to the chest, could hear breath sounds both sides, so didn't think that he had a pneumothorax. The flight crew arrived never between an hour later. It was sometime closer to 5 a.m. And the doctor did an assessment, listened to the chest, decreased air entry on the right, did a point of care ultrasound, which showed no lung rub on the right side. So they said this patient needs a chest drain. I don't know how many people here have put in a chest drain at 5 o'clock in the morning in a clinic in the middle of nowhere when you're tired. So given that this patient was actually quite stable at the time, and the second plane was already in the air and would be there in 55 minutes, the doctor decided to tell the staff in the clinic how to do needle decompression and made sure they had the equipment, and took off with the head injury and a semi-conscious patient. So they had a plane full already. The second plane arrived at about 8:15, and the doctor that assessed this patient found that he had a heart rate of 87, blood pressure was fine, rests were 28 and SATs 92, but he was on 2 litres of oxygen at this stage. He had a pneumothorax on the right, and a chest drain was inserted. Secondary survey showed very little, and he was put in the plane and brought back. Now I've got some pictures which will show issues of putting chest drains in a remote area, but at least it was in a clean clinic and not on the side of the road. So then in the emergency department had a primary secondary survey, a CT pan scan head to toe. He had 2nd to 5th fractures on the right, a right-sided pneumothorax, and a posterior pneumomediastinum, but no other injuries. Spent 5 days in ICU. 2 days in ICU, and then discharged on day 5. So this is the chest X-ray. Anybody see any issues with the tube? When we put in a chest drain for pneumothorax, you really want to get it up to the apex. It's not that easy to do. So you can see there that the chest drain is just, I don't know if this works. It's not working. So the chest drain is pointing towards the heart on the right side. And when you look at the CT scan, it's going all the way into the mediastinum, so that's the vital organs in the middle. So it's definitely not in the right place. It should be way up in the apex. And this is a very common complication of putting chest drains in remote clinics or remote areas. And that will be relevant in the talk later on, because we've got different ways of doing things now and different recommendations. Quiz 2. Now, anybody in the NT shouldn't really be involved in this question, because it's... Anybody know where this is? And what it's called?
Devil's Marbles?
Nope. Different direction. You go east of Alice Springs and a little bit south. Nobody?
Kings Canyon?
No, that's other direction, west. Any NT people? Any NT people? Chambers Pillar, yes. It looks like a very big phallic symbol in the middle of the desert. So it's a beautiful place to visit. Again, it's only like a short trip down the road, 250k on a dirt road. Case 2, so we got a call from St. John Ambulance Comms. They said there'd been a road train rollover. I'm assuming everybody knows what a road train is, a big truck with lots of trailers on the back. And it happened on the Tanami Highway, and there was 2 patients involved, and it was 6:30 in the daytime, and it was the middle of winter. And in the desert it gets quite cold at night time, so this was the truck. At least he had his lights on, but that's about it. Apparently the driver had lost consciousness while he was driving at 110k an hour. But the patient we're going to talk about was a passenger. He was lying on the side of the road complaining of right-sided chest pain. And this happened on the Tanami Highway. So Alice Springs is down on the right-hand side. You go 35k north on Stewart Highway, then you hang a left. And I think that road is mostly dirt, or if there's anything, there's a little strip of tarmac in the middle. But that was about 170k from Alice, where the star is. The nearest clinic is that little loop up the top, a place called Laramba, and there was a remote area nurse there, and a troopie and a driver. So they were the first responders to go to the scene, and they found this gentleman, 44 years of age, lying on the side of the road. He had right-sided chest pain and bruising, shallow breathing, respiratory rate of 50, that's never good, and but otherwise was perfused, warm and well, with a heart rate of 120, no relevant past medical history of allergies or anything like that. We didn't have a plane available, and if you're going to go anywhere, you have to go to Laramba. So the plan was that the troopie would drive halfway, and St. John Ambulance would bring a doctor with respiratory resuscitation gear, so ventilator and blood, because it's trauma, and they'd meet halfway. So at 8:30 at night, the troopie and the ambulance parked rear end to rear end, unloaded the stretcher, different stretchers, different ambulances. It's always great fun. And if you want the RFDS, they also have a different stretcher, which is even better. So they had to transfer the patient onto the ambulance stretcher from the troopie. They had it under the lights out the back of the ambulance, because that way you have 360 access, which is important when you're doing stuff. This patient was thought to have a pneumothorax. On the way to meeting St. John's, the clinic staff had used a sat phone with very bad reception, and had said that he deteriorated and his trachea was deviated. So they'd actually done a needle decompression, which kind of worked but kind of didn't. So when the retrieval team got to him, they actually found that he had a posterior wound with subcutaneous emphysema and a possible flail segment. They didn't put in a chest drain, they just needle decompressed, and that seemed to hold him while they got him to the hospital. He again had a drain inserted in the hospital. and had acute fractures in the right side, 7 to 11. Comminuted displays 10th fractured rib, which is probably causing the pneumothorax. And he spent 2 days in ICU and left on day 7. So just to show that it's not just chest strains in clinics that cause problems, chest strains in hospitals can cause problems as well. This chest strain is in the wrong spot too. And the other thing is it's not in far enough. The X-ray on the right was the pneumothorax, but it's not very easy to see. Now, quiz number 3. Anybody know what animal makes these footprints? Another one?
Camel.
No. It's a marsupial.
Kangaroo.
Kangaroo, exactly. That's the 2 back feet hopping. They usually have a little tail print as well. There's prizes here, you can grab them later, whoever that was. Last case, we had a 000 call from the public. This is always fantastic because they just say, oh, there's a road train crashed, and then they hang up. And you're like, oh my God, where, when, how many people? No phone reception, you know. So eventually we got a proper message. It was on the Lassiter Highway and the driver was injured and there was a lot of damage to the truck. That's all we got. There's a truck there somewhere. Yes, it was a big rollover. The driver was quite badly injured. He had a tire blowout. It was on the Lassiter Highway, which is narrow, but the speed limit is 110, and I think he was doing maybe 111. The patient was on the side of the road complaining of head and chest injuries. So this little red circle, my advice, don't ever have a car accident anywhere around there, because there is nothing. There's no clinics, there's nothing. Kings Canyon Clinic is the little green bit above the red circle on the left, and it's to the left of that. Uluru is along the highway another 150k. Alice Springs is 170k north. So there's no clinics, nothing. We were lucky that this night, or this evening, there was a clinic in Emampa, which is just above the Yellow Star. It's a tiny little clinic, but there was a GP and a nurse in the clinic at the time with a troopy ambulance. So that was a good thing. The bad thing was there was no RFDS plane available again, because we had limited supply. And the plane that was coming back from Adelaide that day had already just about landed in Alice and was now off duty. So we had to get St. John's again to do a halfway meet, and that is a good 200 to 220k south. But when the clinic got to him, he had respiratory rate of 30, tender left clavicle and posterior chest, decreased air entry all the left side. He was tachycardic, diaphoretic, and cool. GCS was 15, but seemed not to be quite fully with it. But he was mobilizing, but he was a bit confused. So the clinic met somewhere south of, about 100k south of Alice. He was tachycardic, respiratory rate was 30, sats were 90, but he was on when they gave him 15 litres of oxygen on a non-rebreather, they got it up to 98, not quite to the 100. So his trachea was central, but he had huge increased work of breathing, had surgical emphysema all down the left side of his chest and on his back and in his neck. They did an ultrasound scan which showed no lung slide on the left and fractured left clavicle, but they couldn't find any other injuries at that stage. He had extreme pain, so he was given some ketamine, and he did dissociate, but then became quite confused and then became apneic. So with a chest injury and apnea, they rushed him to Alice Springs Hospital as quickly as they could. They had an LMA in, but he was intubated as soon as he arrived, and his chest was in pieces. He had that chest X-ray, and those images. You can see that the lung on the left is lots of contusions. He's got fractured ribs, 1 and 2, which is always severe trauma. If you can fracture the first and second rib, that's pretty a lot of force to your chest. And you can see his fractured rib clavicle on the bottom right there. So quiz number 4. Anybody know where this is? Cradle Mountain, yes. Beautiful spot. Not in the Northern Territory, because there's water. Okay, so chest trauma and chest drains and thoracotomies. We're just going to talk a little bit about that. Trauma is the leading cause of death in 0 to 40-year-olds, and it's usually motor vehicle crashes. Blunt trauma seldom requires surgical intervention. It's usually penetrating trauma, so gunshot wounds and things like that, that need to go to theatre early on. But blunt trauma is usually lots of pain, lots of respiratory problems, contusions. You can have pneumothorax, hemothorax, pneumohemothorax. And the international trauma guidelines state that if you do have any pleural disruption, then you do need to put in chest drain. So that's about the only thing that you often need to do for chest trauma. Surgical exploration for blunt trauma is about less than 3%. And usually what they try and do is, the new recommendation is to do minimally invasive procedures. So when I was growing up as a doctor, I was told the bigger the tube, the better, that you're going to put into the patient's chest. And they gave a lot of physics reasons why the radius of the tube, if you reduce it, it's 4 times reduced volume that can flow through it. Lots of weird physics that I never understood anyway. But they have never shown any studies to prove that a bigger tube is better. And quite to the opposite these days, they have done some random control trials to show that small bore pigtails are actually probably better. They don't block, and that was the big issue that people thought, if you give a small tube, it's going to get blocked with anything that's in it. They don't block. They cause a lot less pain, less time in hospital. They have the same complications as a big tube. So that is one of the recommendations from these new international guidelines, and that was in 2019. So lots of questions you have to ask about blunt chest trauma. What are you going to do if you need to decompress? Where do you put the needle? Where do you put the tube? Do you use a needle? Do you use your finger? Do you use a tube? Do you use a big tube, small tube? And then where do you insert the chest drain? I did not know until I was reading these papers that there are lots of different alternative places to put them. And then other considerations are, do you put the tube in the field? Do you put it on the side of the road? Do you put it in the clinic? Do you wait to get to hospital? Do you need to put a tube in at all? And then other considerations are, of course, infection risk, analgesia requirements, and the transport time. And particularly for us in Central Australia, transport isn't a 5-minute ambo drive down the highway. You can have 4 to 6 hours of troopy, flight, ambulance, and that's if you've got a plane. So, and then the type of trauma you're obviously not just going to have one issue. If you have trauma, you can have trauma to other places: head, neck, abdo, pelvis. So it's never just one thing. But this talk is just about chest. So there's 2 different settings of chest drain. You can have the Manaldi approach, which is second intercostal space, mid-clavicular line, or the Bullow approach, which is 4 to 6 intercostal space, anterior or mid-axillary line. If you go up here, you have a better chance of going into the lung itself. if you go down here, there's a fissure between the upper and lower lobes. That is where the tubes on both those X-rays that I had was going, and that is the usual site where most of us will put a chest drain. But there's no differences in complications. Mostly it's putting it in the wrong place, especially in out of hospital insertion. Pre-hospital chest trauma, you got to remember you don't have an X-ray machine. A lot of these clinics don't even have ultrasound, so unless the doctor brings the ultrasound, if you forget that, you got nothing. But clinical examination is probably the best thing anyway. Clinical exam auscultation is highly sensitive and specific. Adding an ultrasound point of care test will make things more suggestive of pneumothorax or hemothorax. The most important thing for us is repeated physical exam and identifying the issue before it gets too serious. So if you can identify a pneumothorax before it becomes a tension, that's always a good thing. And you also have to remember, for us in pre-hospital, if you're in an airplane, you cannot listen to somebody's chest because all you hear is an engine. So best to diagnose these things before you get in the plane and before the pilot switches on the engine. And even if you could listen and find out, there's not a lot of room in the back of a PC-12 plane to put in a chest drain either. So we usually try to diagnose everything and sort everything out before you package them into the plane. The other thing I just thought I'd put in was, if you have a chest trauma with cardiac arrest, then obviously you need to put a finger in both chests as part of your resuscitation and CPR. The issue with that in Central Australia is distance and time taken to get the patient to definitive care is usually too long, so usually these patients will die. The size of the tube, so ATLS and British Trauma Society always recommend a large bore tube, 28 to 30 French. It's basically like a Wavin pipe going to your chest through your ribs. And they say the law of physics, internal diameter versus flow rate. But there's never been a randomized controlled trial to support this view. And it's just what everybody used to do before, and what we were told to do as baby doctors. And we now tell the baby doctors, this is what you got to do. But there has been some studies done, and this one was done by the Journal of Thoracic Disease in 2019. A pigtail or a smaller bore chest drain can generally be accepted by most thoracic surgeons as acceptable to insert in blunt trauma to the chest. They also did a randomized controlled trial of 40 patients comparing a small pigtail with a big silicone tube, and they saw similar complications with both, but the most important thing was the smaller tube actually showed less pain relief required, and a lesser length of stay. The management in blunt trauma is gentle suction versus free drainage. They say gentle suction is better and will allow for quicker healing. They also now talk about using talc to reattach the pleura even in trauma. Most complications are position. That was the main thing. You do have more complications if you do it in a pre-hospital setting versus in a controlled hospital resus room. And specific things such as subcutaneous bleeding, dislodgement, infection, laceration, or perforation of other organs, or complications that can happen at any chest drain insertion. Now will be the hard question. Does anybody know where this island may be? My accent might give it away a little bit.
Aran Islands.
Nope, south of that. It's called Dead Man's Island, and it's just off the coast of Kerry. I just had to put in something different. So these guidelines are actually quite interesting to read. They're the Royal College of Surgeons in Edinburgh, the pre-hospital management of life-threatening chest injuries, and there was a consensus statement made in 2016 with some updates in the last 10 years. They looked at the frequency of major trauma patients, about 200,000 patients, and they found that tension pneumothorax was the most common thing that you'd find after a flail chest. And a flail chest, they explained was three or more fractures of ribs. As you can see, open pneumothorax is pretty rare, as is massive hemothorax and cardiac tamponade. So, even though we learn about all these things, the most likely thing you're going to have to be managing is a flail chest, which is pain management, and possibly pneumothorax under that, plus or minus tension pneumothorax. Okay. General management of anybody with blunt chest trauma, oxygen is very important, keeping their sats between 94 and 98. Positioning the patient. If they can sit up, you sit them up. If they've got other trauma, such as a C-spine, then you're going to have to lie them down. Do you lie them down good lung up or good lung down? They say good lung down, and the reason for that is both oxygenation and perfusion of the lung, not just oxygenation. And early and effective analgesia is very, very important. So a good thing here, if you can get it, is the green whistle that the ambos have. Not always available and not in the hospital. Ketamine is a fantastic option. Ketamine, a bit of fentanyl is also good. I never forget paracetamol and ibuprofen as well. They're pretty good too. Tension pneumothorax. I've just taken out a few things from these guidelines. Tension pneumothorax, most important thing is clinical examination, looking for signs and symptoms of a pneumothorax. Adding an ultrasound can be beneficial if you know what you're doing with an ultrasound. Progressive decompensation is what usually happens. So the earlier you can decompress a pneumothorax, the less likely it's going to develop into a tension. Chest pain, respiratory distress, not always good signs. Tachycardia and decreased air entry, often later signs. If you've got a patient who's on positive pressure ventilation, so intubated, ventilated, then they're most likely going to have a tension pneumothorax. So if we have any patients who have chest trauma and any hint of a pneumothorax, and you've had to intubate and ventilate them, they always will get either a finger thoracostomy, so a finger into the pleural space, or a tube, because that will develop into a tension. Needle decompression is good when it works, but it's a very small needle. It needs to go a very long way, and quite often it doesn't get to where you want it to get to. So sometimes if one doesn't work, try a second one. If that doesn't work, then you really need to put your finger in a hole and give the air some space to get out. Sometimes even if the needle decompression does work, it can block off again. So you can either try and put another needle through the same hole or put another needle next to it, but they do often close up again. You can also do needle decompression elsewhere, so 5th intercostal space, mid-axillary line, or anterior axillary line as well. But my recommendation is stick a finger in the chest. It's not going to block off again, and you've got somewhere for the air to get out. So they're the two spots. Green spot is 2nd intercostal space, mid-axillary, on mid-clavicular line. The red one is anterior axillary line in the fourth or fifth rib space. In pediatrics, they'd say that you can go down half the length of the humerus, and you're usually in the right spot in the opposite chest. Again, there's a little graph there that shows the location, the thickness of the chest wall. That's the little needle that you're going to be putting in. It's just it's like an orange cannula, but it's longer. But you see, fourth or fifth intercostal space, anterior axillary line, is actually the space that's closest to, it's got the smallest area that you've got to get through, and it's also got the best outcome, or least failure rate. An open thoracostomy, so this basically is, you make a hole in the chest, you put your finger in. It's not the first line treatment for tension pneumothorax, but quite often it'll be what you'll end up doing to treat it. It should always be followed by a chest drain. Whether you have to put that chest drain in there and then, you could wait till you get the patient to hospital, and it could wait for a few hours. So we would usually do a needle decompression and then put a finger thoracostomy, and then bring them to hospital where they can have definitive treatment. You can use the same finger thoracostomy site to put a chest drain in. Chest drains may be needed in the air medical retrieval, but a finger will do the trick while you're waiting to get them to hospital. You also have to remember cabin pressure when you go up. If there's air inside a small space, it can expand when you go up to 20,000 feet. So often we have to ask the pilot to fly at ground altitude, but the problem with that is it takes longer, it's slower, and it uses more fuel in the plane, which is important to get you back to where you came from. So, and this is the finger thoracostomy, and we have these kits. We have these small kits in our bags. So you basically just, some local anesthetic if you have it. Quite often we don't. So it can be a little bit of a nick with a knife, a blunt dissection with a forceps. Usually you get the forceps to the pleura and you pop it in and you'll hear a hiss and you'll feel it give as you're pushing it in. Usually I'll use a wide toothed forceps, and then you can put your finger in the middle and screw your way in till you feel the rib. You go over the ribs, and then you can feel the lung underneath the finger, and then you know you're in. A nice gory photo of a finger in the chest, and you can see how far that finger is in. It's up to almost to the second joint. So that is a proper finger thoracostomy. Management of tension pneumothorax is dependent on your expertise. They have done studies training HEMS paramedics, so helicopter emergency medical service paramedics, have been trained in, I think it was Victoria, and they've also done it in London. They were trained to do finger thoracostomies, and it was found to be, it took, I think, half a day training, and they did a study which showed similar outcomes to a doctor or the paramedics doing the same procedure. So it is definitely easy to train, it's easy to do, and it's definitely going to work. And a finger in the chest will actually might save the patient and get the patient to where they need to be so they can get a chest drain put in there. So retrieval thoracostomy, we rarely do it. As you can see with our 3 patients, one of them got a chest drain, which was definitely well in the wrong place, but we don't often put chest drains into patients in a remote location. A finger thoracostomy is just as good, and when you get to a sterile hospital, then you can put a drain in. We rarely do this in Alice Springs, but the advantages are that it's fast, it's very simple, easy to train, easy to teach. We have guided remote area nurses how to do this once or twice before while they're waiting 2-3 hours for a plane to get to them. We can also teach them or tell them how to do needle decompression. But the finger in the chest is very simple. You just tell them where to go, make a nick, make sure the nick is big enough, dissect down to the pleura, pop your finger in, and you'll feel this. It's like a sponge when you get to the lung. So it's easy to do. Disadvantages are that obviously it's going to be the same thing: bleeding, infection, and sucking chest wounds. So you do need to put a dressing on it sometimes. There are specific fancy dressings you can get these days. They're never available in the ENT. They cost too much money. Thoracotomies, so cracking open the chest is something you'd see on MacGyver or something, I don't know. It's rarely done, never really needed for blunt trauma. Usually this kind of thing is done for gunshot wounds or stab wounds to the chest. And ATLS again give you some guidelines on when these patients would need to go to theatre. But again, it's mostly penetrating trauma that will cause all this. Blunt trauma, the most important bit is down the bottom. Blunt trauma with no signs of life, then a thoracotomy is not going to do anything for that, and it's not actually recommended. Alright, I think that